Everybody sounds very energetic for this evening. We should see it at midnight tonight. How about that? Hi, everyone.
To see one another.
Yeah. We're a little close. Sorry. Jean and I are a little close. So I'd like to call the meeting to order and thank everyone for coming today. It is 5:01 p.m. Eastern. For attendance purposes, I'd like to identify members who have joined by telephone. Is there anybody on telephone here? Or are we all WebEx? I don't see any telephone. I see names staring at me, all in front of me. So Joy, Natalie, Peter, Glenn, Amy, Sarita, Michael, Kelly, Jessica, Elena, John, Gord, Douglas, John. We've got everybody. Gary as well, and Pat. So thank you, everyone. A reminder to all of us to mute your microphones on your technology so as to limit any feedback and back noise during the meeting. Please unmute if you wish to ask a question or make a comment and identify yourself prior to speaking. I'd like to welcome everybody today in these continued unique times, especially all of our board members, our senior leaders, and our special guests. A very special welcome to some new board members. So Andy Dean and Pamela Wakowicz, who are also members of the board of the Research Institute, welcome today. So I see Pamela, and where's Andy? Is Andy? He'll be coming on. So hi, Pam. I'd also like to welcome Kelly Missouri-Collins, who is the new Executive Vice President of Research, Quality, and Academics. Kelly? In this role, Kelly is going to work to advance the hospital's scientific and academic missions in the future while fostering our continuous quality improvement. So Kelly, welcome. Nice to see you. The chair report is included in your package for information purposes. I'm sure most of you have taken a look at it. Some highlights of it. Last month, I proudly announced on behalf of the entire board that Dr. Rhonda Crocker-Ellicott has been appointed the new president and CEO of the Thunder Bay Regional Health Sciences Center and chief executive officer of our Research Institute, effective November 23rd. So we're a little over a month and a half away from that. Rhonda will lead our hospital to the development, along with the senior team and all employees, in the development of our new strategic plan and health system transformation. So we officially welcome Rhonda with this board meeting. I'm also grateful for the man to my left here, that he's going to continue to provide his leadership, his outstanding leadership as president and CEO of our hospital and the Health Institute until he retires.
Or he's talking.
Until he retires on November 20th. So Jean, thank you for that. And no doubt we're busy here as we continue to go through COVID and all of the concerns that are facing the hospital.
If I'm allowed in.
If you're allowed in, yes.
I have this screening.
Yeah. On behalf of the entire board, so for many on the line, I extend my appreciation to all the hospital staff, the professional staff, for your extraordinary response and sacrifice throughout the entire pandemic, and it continues to today. It cannot be overstated, and that's from every member of the board. Your dedication has been nothing short of remarkable. Despite the pressures that we've had and the long hours and constant tweaking and modifications, this team proves itself time and time again. So thank you for that. You guys have truly been exceptional. Thank you. I also want to thank the community members across Northwestern Ontario for minimizing the spread of COVID-19. I know we're all at a heightened alert these days with around some of the numbers that we see coming from our colleagues in the South, but what we've done here, your sacrifices, closing businesses, accepting to wear masks, canceling gatherings, trips outside the region, physical distancing. For those you love, those will not go in vain. We're looking at Thanksgiving weekend. I myself and my family were talking about how we're not all going to be able to get together, but those are the sacrifices that we need to continue to make. So thank you for that. It's important that we maintain our diligence, and together we're going to keep everybody healthy and safe. So thank you very much for that. I note that we do have quorum. We have enough voting members that we can proceed. So I'd ask if there are any conflicts of interest for anyone to declare. I'm going to look around the table and up on the screen, so I see none. And with that, I'd ask for a motion to approve the agenda. I note that the agenda was pre-circulated and that the movement of the motions have been pre-assigned. So we're continuing with this theme as we go throughout our board meetings. We're going to pre-assign the motions to certain directors to maintain the flow of the evening. So the approval of the agenda was moved by Gord Wickham, seconded by John Friday. All in favor by show of hands. Carried. I'd now like to turn things over to our Chief of Staff, Dr. Ned, to open up tonight with a patient story. Dr. Ned?
So thank you very much, Mr. Chair. I have permission from the family member to share this. It's a story that really highlights when systems go well, how different systems can come together and really change the outcome for our patient. So this is a 68-year-old wife and mother who lives about an hour outside Thunder Bay, who was in Thunder Bay at that time shopping in a local grocery store. This was July 10th, so during the whole pandemic time. And she was in the produce aisle where she collapsed at approximately 1 p.m. Bystanders called 911 immediately. The EMS team was in the vicinity, but en route to another call. However, the team was rerouted to the store due to patient priority. EMS received the call at 1:04 and was there at 1:06. The patient was found at 1:08, lying on the floor in the store, alert and responding to questions appropriately. However, she was presented with a left-sided facial droop and left-sided weakness. A possible stroke was assessed by the EMS team, who immediately transported, and during the transport, it pre-alerted the emergency department at 1:12 p.m. The emergency department was able to pre-alert the neurologist who was on call 5 minutes prior to arrival. The patient entered the emergency department at 1:23. The code stroke was called at 1:24, assessed by the emerge doc at 1:25, and the neurologist who was already there because of the pre-alert. On initial assessment, the patient received a score of 5 on the CNS score and 14 on the NHS, signifying a significant stroke. Initial CAT scan was completed within 12 minutes of arrival. Images showed evidence of a clot in the right middle cerebral artery, which is one of the main arteries on the right side, controlling the left side of the brain. TPA, which is the clot buster, was prepared, and the bolus was given at 1:45. So within 45 minutes of having the stroke. The team from emergency arrived to TPA started. So by the time they arrived in emergency to TPA was 22 minutes and less than 40 minutes after the event happened. Dr. Marchuk, who was a neurosurgeon, was in the building and hearing the code stroke overheard, attended to evaluate the patient. Patient was a candidate and was deemed to be a candidate for endovascular thrombectomy, which is where you go in with a catheter into the brain, find the clot, and pull that whole clot out rather than just using the clot buster. So, in addition to using a clot buster. So the consent was obtained, and angiography suite started preparation for the procedure. However, while the clot buster was infusing, the patient started having significant headache. So we had to stop the clot buster, get into a CAT scan, and make sure that there was no bleeding because of the clot buster. There wasn't, and the clot buster was resumed. The patient finally made it to the angiography suite, and at this point, the procedure was started at 3:04 with the needle into the patient. After this, the patient was transferred to the ICU, and during the procedure, the clot was removed completely, and full reperfusion was obtained by 4:07. So they managed to get the full perfusion into the brain. The patient was transferred to the ICU. Over the period, the neurological status or the patient's neurological function continued to improve to the point where there was only minimal effect that was residual. So this, and the patient's doing very well now. This story highlights a lot of teamwork, not just within Thunder Bay Regional, but there were 19 people across 3 organizations, 5 departments within Thunder Bay Regional, 4 physician specialties who were involved in the hyperacute care of this patient. So the team members were 1 grocery staff, 1 EMS dispatch, 2 paramedics, 3 emerge nurses, 1 emerge physician, 1 switchboard staff, 1 lab technologist, 1 CT technologist, 1 neurologist, 1 stroke nurse, 1 neurosurgeon, 1 nurse in the EDT, 2 MRI technologists, radiation technologists, 1 intensivist, 1 ICU nurse. And that's what it took to make sure that the function of this patient was sustained. So this is a great example of when things come together and what we're capable of.
Wow. And that's an incredible story, actually, and amazing example of teamwork. Any comments for Dr. Ahmed? It's a lot of nodding heads, I see. Good. It's a great story. Thank you for sharing that. We'll move forward to the consent agenda because we have a motion before us. Reads that the Board of Directors approves the Governance and Nominating Committee minutes from September 16, 2020, approves the Patient Safety and Quality of Care minutes from September 9, 2020, accepts the Q1 2020-21 wages and source deduction attestation for the Health Sciences Center, accepts the Board of Directors work plan for 2020 and 21 as presented. We have a mover in Pat Lang, seconded by John Hatton. All in favor? Show of hands, carried. Thank you. I'll turn things over to our CEO for his open board meeting report.
Is there someone on the phone? Do I need this? I don't think I need this because we have this. Okay, so we don't need that. Okay, so everybody can hear me? Okay, so my board report was circulated, but I wanted to highlight 3 items that are keeping us on our toes, that's to say, awake at night. Financial impact of COVID-19. So we were short of not being able to meet our payroll and supplier bills. Thankfully, both the foundation came to rescue, and finally the Ministry, Ontario Health North, with Ontario Health North support, forwarded advance payments. And I'm looking at Peter. We are still waiting for some money to come in, but we're out of the ditch, literally at this point.
Yeah, so we're in a position now where we're not bumping up against a $15 million line of credit, and our vendors, net 30 of them, net 90 vendors, threatening us up by supply. So we're in a far better financial position. We're not in a good financial position, but a manageable.
So strategically, we were advised by the Ontario Hospital Association to reach out to our MPP, which we did. Thanks to Peter and his team, we prepared a one-pager summary of our financial challenges in 3 buckets: revenue stream, the loss of revenue from parking and accommodation, and I can't remember what the third one was, but we will share that with you. We reached out to our MPPs. So far, we've met with Michael Gravel, who took it upon himself, and we shared with him. Peter sent him a briefing note asking for his support in addressing our financial challenges and enrolling the government support. So he's already reached out to his colleagues in Parliament, and we hope that this is going to steer some response. The OHA, their president was impressed with what we did so far. We are scheduled to meet with Ms. Monty Farrell with the same ask. And we also enrolled the CEOs in the region to share with us their respective issues, challenges, so that we can then reach out to Minister Rickford as the regional MPP and Minister to share with him our hospital system challenges in addressing the COVID pressures, financial pressures. And we hope that this will prompt some more rapid reaction in terms of funding the cost of the assessment center, the additional staffing required to man the screening and on the units as well. The other item that is high on our priority list, and I know you're all very concerned with the wait list that has accumulated when we had to stop doing surgeries and some procedures. So we have resumed our operations. I don't have the exact numbers, but I know Peter and Zaki are here. I know surgeries have picked up. We've increased volumes, and we were aiming for trying to reach 120 to 125% of last year's surgical volume. And we were aligned to reach that number. I'm not sure we will be able to sustain it should there be a second wave in the region, but we are still maintaining pressure to increase our volumes in DI, in surgery, and wherever we have wait lists. The other pressure we had to address was the assessment center. We had to take over from the health unit the scheduling of tests. If you read the papers, you saw that the government came up with a new direction last Friday that we were no longer to test walk-ins, which we have not done unless in the drive-thrus that we operated from time to time. Otherwise, all our assessment center operations were based on a schedule precisely to avoid having long lineups of people waiting to be assessed and potentially exposing themselves to this viral infection. So it seems we were thinking ahead of government because we didn't have to stop testing this weekend. We have appointments 7 days a week, and we currently operate the call center to manage the appointments. We also have accessible to the population an online app that people can just dial in and schedule their own appointments on themselves. And we lastly expanded the assessment center operation thanks to the support of the Confederation College. We were successfully online to open a new assessment center. I'm not supposed to say new assessment center apparently, but let's say expand the assessment center operation in UDIG in Confederation College. I had the privilege of visiting the center with Andrea Doherty, who leads that operation last Monday, and I was quite impressed with how everything is set up. There was no lineup. Patients were processed as they came in already. So kudos to the team for a quick turnaround because they had to turn around on a 10 cents. Initially, the message was that we were supposed to accommodate school teachers and students on a walk-in basis. And we were advised Friday, I believe, that that was no longer the direction, that we had to take appointments. So we turned around and were successful in managing that. So with that, unless Peter, Zaki, you have anything else to add? Or I can answer questions if you have any questions.
Are there any questions from those on the line?
It's Pat. I do have one question, and thank you for that update. And your report was well detailed, and I appreciated that, John. In terms of the not taking appointments, was there a logic? In terms of not allowing walk-ins, was there a logic behind that?
So I can take that one. So we were moving toward a walk-in center for the school kids in order to try to help the system and really manage for parents when they wake up in the morning and they have a sick kid to be able to just go to the assessment center. What we were planning was if they showed up and there was a spot, we would put them in right away. And if there wasn't a spot, we would give them an appointment for that day so that they could return so they wouldn't have to wait in line. The ministry, about 15 minutes literally after we made our announcement of how we were going to function, let us know we're no longer allowed to do that. They have to pre-book ahead of time. I think the pressure from the ministry really was about the lines that were going on in Ottawa and Toronto and people waiting in line for 8 hours and not wanting anybody to do that. It really didn't take a regional approach to what we were doing. But we really, as Jean said, had to turn on a dime and by from Friday and Monday turn around a system that would allow people to book ahead of time. So we created an online system. So what happens right now if you have a child in the school system or a sibling or a parent or an employee of the school system, you go online and you can book a same-day appointment. The appointments come at midnight and you can only book for that day. And where we're sitting right now, we're not using the 150 a day that we need. We had a meeting with the school boards this morning with 2 of the school boards, and they're incredibly grateful. It's working really well. If they have staff who are sick, they're turning around and getting swabbed that very same day at the assessment center. So it's working quite well. We think we have enough to meet the demand. The issue really is then the tests actually are taking about a week to turn around at public health because the lab system in the province is so backed up. So that's a bit of a separate issue, but we're getting everybody swabbed.
Thank you.
Michael?
Yeah, I was just going to ask Sean when he talked about the not so new testing center at the college. How are we continuing to support those centers, or are we expected to?
So this is new. We had to expand because of the schooling demand. EMS were providing that service, but we're overwhelmed with calls when school resumed. So we were asked to expand at Con College, and at Con College gratefully reserved a building that is only for testing, for assessment. So we're not crossing paths with any other population. The plan is to operate this as long as there is a demand. We were very taxed from a professional staff perspective. We didn't have the nurses, so thankfully home and community, the health unit helped staff the assessment center for the next month. And based on volumes, and as I hear Peter mention, we will have to determine if we maintain the operation past that month or if we simply close down and have people redirected to the hospital assessment center.
I'll just add one other thing. So, Michael, right now the 2 nurses are from home and community care. We have them for a limited period of time. We have to keep going. We're working on actually our retired nursing pool to try to pull from that. But in addition, the assessment center, because we're leading assessment for the city, is working with primary care to try to increase swabbing within primary care so that if a physician or a nurse practitioner is seeing a patient and they're unwell and they think, they need a COVID test, they're not having to send them to the COVID center for testing, but can actually do it in their office. There's little bits of it happening through the city in different places. The LU and College Clinic, I think your clinic, Nishnawbe-Mushkiki is doing a little bit. Norwest is doing a little bit, and we're working with a larger primary care group right now to make sure that they all have testing in their offices to test patients who are there, not to be a walk-in or a booked appointment for people who are symptomatic, but for people who are in the primary care office, are sick, and the practitioner believes this person needs a test. So that's to come.
Thanks.
Any other questions?
It's Natalie, Matt, if I may.
Yep, go ahead.
And I apologize ahead of time. If not so much a question, and I apologize, but I can't go and not say anything about Zaki's story. It just keeps going over and over in my mind, the patient story he shared. Is there any way that all the parties involved can be shared, the story can be shared with them to paint the picture of the impact of every piece of the puzzle, made the puzzle all come together successfully? I think all those parties need to be given the credit, and I think it would be a shame to miss out on that opportunity.
So thank you for that, Natalie. So that has already been done, including the grocery store clerk that started the alert. So thank you for that. Yes, we have reached out to all the parties involved.
Anybody else? Questions, comments? Okay, thank you. Thank you, John, for your updates. And Dr. Ahmed, we'll turn it right back to you for your report, which I know we're going to talk a bit about COVID-19.
Yeah, so I think the biggest topic, continuing on from what John talked about, was the reintroduction of clinical activities and impacting patient care. So as you know, as most of us have seen the report, there's several thousand procedures that were delayed over secondary to the COVID-19 delays and closeout. We did ramp up our operating rooms to 100% capacity, so all of our operating rooms that should be running at the time of in September are currently running. Some of the limitations were some of the staffing, which is getting resolved. Our next challenge, however, because of the second wave, will be our bed capacity. So as it is, we're running at fairly high numbers with our bed capacity, and if we get COVID, that may negatively impact what we're able to do from the service provision standpoint. We're working on solutions for that. So things like the medical transitions clinic, which will allow patients to be discharged a little bit earlier, short stay units, which is currently in development, as well as the admission avoidance by having an admissionist in emerge, to make sure that the patients who are being admitted are the patients that actually need to be admitted. So those are some of the solutions we're trying to use. We will, as John mentioned, try to work with our partners in the community to try to make sure that our patients are transported back to the region quicker, as well as to St. Joe's. Our recruitment, despite the COVID-19, and this is why in my report you'll see so many names, and I'll with the permission of the chair, actually use all those names because I think it's fairly impressive at how successful we've been, despite the fact that some of these people had never seen Thunder Bay because they could not come up for their usual site visits, at how successful our recruitment has been. So we recruited Dr. Sarah Koch from internal medicine, Mike Rittiger from orthopedics, Zohar Salaf for radiation oncology, Margarita Losa plastic surgery, Cody McMillan and George McKay from emergency, Jamal Atawani from cardiology, Renee Vachon from psychiatry, Kobus Hopfleisch from anesthesia, Trevor Woods for colorectal surgery, Anastasia Shamsirova for dermatology, which was a huge need for the last 3 years. Dr. Chrissy Polke from ENT, Dr. Colin Rumbold from gastroenterology, Sarah Scapanello from psychiatry, Deanna Budenhouse from obstetric, Carlo Hinkala from hospitalist, Shika Bansal from anesthesia, Tess Cotterill from anesthesia, Yuvraj Kodiswaran from anesthesia, and Kaelin Safovich from anesthesia. So as you have been informed previously, anesthesia was a huge shortage, and one of the reasons why we couldn't open up some of the ORs before COVID hit. So that we're getting up to complement, which is incredible. Dr. Al-Qatari from hematology, Dr. M. Zakaria from urology, Dr. Shimuzi from gastroenterology, and Bishop Amwani from ophthalmology. In addition to this, we also have our first international fellow, as you may have read. So this is in urology. So this would be our first fellowship program that we're working with Noslin very closely. And that's a great opportunity and speaks highly to the success that our urology department has had so far. In terms of COVID-19 updates, so the second wave has started. We're in the midst of it, and probably at the beginning of it. And we expect there to be increasing numbers, just like across Ontario and Canada. Eventually in Thunder Bay, I don't think we can stop the influx of the cases. What we can stop is to try to reduce some of the spread, as Matt mentioned, in terms of the activities that we perform. But from a hospital perspective, it was really important for us to put in the restrictions for travel. We know that the Thunder Bay District Health Unit has made recommendations, and unfortunately that's all you can do as a health unit, is to make recommendations until you can have orders that you can close out. But as an employer, I think it was really important for us, and being one of the largest employers in Thunder Bay, to send that message to the community that it is not okay to travel, because our numbers are 14 to 15 times less than anywhere else outside Northern Ontario, and 36 times less than Toronto area and Peel area. So those were important for us to maintain, and due to the limitations of our health human resources and healthcare provision in the community, and the inability of our patients to be able to go elsewhere if we close down, this is a big risk to the organization, and hence at the IMS we recommended that we have that travel restriction in place. I'll stop and take any questions if anyone has any.
I have two. One, can you expand on the recruitment and why you feel we're having, I know some of the things we've talked about, but maybe for the greater board to hear why. And two, are you saying from a COVID standpoint that because of our remoteness and that this is the hub, if you will, that we're at an increased risk in comparison to other areas? And if so, what are some of the numbers that are going around? Is that fair to even say, like, we start seeing 30 cases a day, are we in trouble? And that sounds basic.
No, absolutely. Actually, so this was very well debated, and it's still being debated. I just sent an email this afternoon on this. So the first question first. So in terms of the recruitment, one of our successes, and I'll follow this with some bad news, but the successes was our recruiting specialists. So we had hired a recruitment specialist about a year ago now, who worked with Health Force Ontario, which does a lot of locum work for elsewhere, was the president of the Canadian Association of Physician Recruiters. So quite a qualified person into that position, Jamie Sitar, and he was fantastic with what he did and how he interacted with people, and his hard work and just the system knowledge was very good, and that really helped us. Unfortunately, he's just been recruited by Okanagan to do all of Interior BC's recruitment.
Oh, I didn't know that.
So unfortunately, we just announced it this week. And he's going to be moving out to Okanagan. But having said that, he's put in systems in place, and really the whole systematic approach to how recruitment should work, that I think that'll help us moving forward. And we've also built a critical mass, and I think that's going to keep going. So as far as what do we use as a trigger for knowing we're running into trouble? And I don't think anyone has that number off the top of their head. So we did, so I worked with the Ontario Health North Surgical Reintroduction Committee. So across the North, working with public health, working with primary care, and some of the experts, we looked at the data it suggests that if you have more than 40 per 100,000 point prevalence, so if you have a population of 100,000 people and you have 40 active cases in the community at this point, that suggests that you are at risk of having significant spread in the community where you may not be able to capture everyone, but at the same time, they may be a high risk for asymptomatic spread. In our recommendations, one of the things that we're using is our triggers both at the IMS level as well as surgical reintroduction level in terms of preoperative testing. What we're recommending, and for everything else that we're doing at the IMS level, is using a number of 20 per 100,000. So using the half the recommended number to start the trigger of we're being hyper-vigilant, if you will, in terms of knowing when the cases are increasing at a certain rapidity.
Thank you. I've got Michael, then Pat, and I don't think I've missed anyone yet. So Michael, then Pat.
Yeah, you missed Mike.
Thanks, Dr. Ahmed. The section related to long-term care, how is that going to affect your hospital capacity if there's an outbreak in regards to, I'd like to know a little bit around the significant numbers. That's one question. The other one is the COVID update. Is this travel restrictions going to affect your locum individuals trying to come from the region or such?
Yes, absolutely. So I'll take your second question and I'll defer the first question to Jean. So the second question about locums and how it's going to be affected by the travel restrictions. So that was one of the biggest challenges. So we looked at the scientific data, and you may hear this from people that we're using a number of 7 days rather than the 14 days that you're used to hearing. And some of that is based in science. So there have been 2 retrospective studies that have looked at how long people are asymptomatically spreading for, and it's anywhere between 4 and 6 days. So we use the number of 7, after which they would still have to have screening. So if they become symptomatic, they would not work anyway. But by that time, the risk of asymptomatic spread is almost gone. In terms of locums, what we did was we know that we're fairly locum dependent in certain areas. So Emerge being a great example where 84 shifts a month are covered by locums, despite their recruitment efforts. Those were the challenges. So what we've done is they're going to continue wearing masks, and we know that with masks, your chances of spreading it to other people is very low. In addition to that, we will be swabbing them when they get here. So if they were exposed, not 100%, but if they were exposed and are asymptomatic, so we know on day 1 that they're starting, they're not going to be asymptomatic spreaders. However, there is a small risk, and that's a risk that we're going to minimize with wearing masks, of them becoming positive in the following 4 days. But that's a risk that we'll mitigate with masks.
And what was your question exactly about long-term care?
The beds, the numbers, it talks about a significant number of beds lost. I'm just trying to figure out what the numbers.
Yeah, so the impact is bigger outside of Thunder Bay. Thunder Bay, we're fortunate that, for instance, HRM is a fairly new construction, and they had their room arrangements were such that there were no 3 or 4 bedrooms in that building. So the new direction of the province is not to have more than 2 people per room, and that's impacting the older buildings, especially in the region. So for instance, today we were in a meeting, and Kenora was saying how challenging their situation is with that new rule compounded by an outbreak in one long-term care home in Kenora, which means there's a backlog of ALCs at the Kenora Hospital of the rate. So it said about 50% of their beds are occupied by alternate level of care patients. So we don't have that situation. I may remind you that we have 64 transitional care beds still in operation, and we've also been asked by the Ontario Health North to identify another 30 beds by the end of October, I believe. So that should there be another surge and the hospital was overwhelmed with demand for admissions for COVID patients, we would be able to transfer another 30 ALC patients outside of the hospital. So we have a plan that's being implemented as we speak. We're still advising those impacted by that project, but we're confident that we will have those additional 30 beds that will definitely help relieve some of the pressure.
Okay, thanks.
And we've got Pat and then Sarita. Pat? Your volume, your mute button. There we go.
Yeah. Okay. There we go. Thank you. In our materials and also in the paper, we read a lot about ethical frameworks for decision making, and I know that we've got that in our materials as well. And I'm wondering if not necessarily today, but at one of our future meetings, you could talk to us about the ethical framework and how we're using that in relationship to resumption of care, but also in terms of application of limited resources.
Absolutely. I think a separate presentation would be more helpful in that manner.
Thank you. And then my second question is in reference to the impact on staff when they have to take time for self-isolation. How does that affect their sick time? Do they have to use their sick time for that, or are we handling that some other way? Because I do hear from other places that that is a concern.
So yeah, I can take that. So we gave staff a heads up that we were going to be limiting travel. So if they traveled prior to us giving them the official start date, we're actually paying them to isolate. If they choose to travel after we've notified them that they're not to travel outside the region and they have to isolate, then they're not paid for that time. If they had an exposure and need to isolate because of exposure, that's a different situation where we're looking at paid sick time.
So that they won't have to use their sick time bank.
Correct. Our sick time bank is a little different here. We don't have a set number of days that are in your sick time bank. We look at an overall average, and if you go above the average of the institution, then there's a meeting with your manager. So there's not a limit to that necessarily unless we're talking about long-term sick time. So for short-term sick time, that's not an impact.
Thank you.
Just for clarity though, if I travel after October 6th,
I was supposed to travel to Quebec this weekend. I canceled my trip, but had I decided to maintain that trip, I would have had to come back and self-isolate without pay for 7 days.
So you're not going to get sick time at all in a situation like that.
Okay. Making the choice to go after we've notified you, we don't pay you to isolate. Now, keeping in mind that we need to balance essential services at the same time. So who is this staff? Where do they work? How critical is it that they're here? All of those pieces similar to the locum positions are something we have to contemplate at the time. We also recognize that staff may have to travel essentially. If a sick family member, if my mom's dying, I want to go, the impact of me coming back, it's a different discussion with the leadership around what we're going to do for that person.
Thank you. Sarita?
Thanks, Dr. Ahmed. This is an incredible report. I'm so impressed, and in particular, you can appreciate the number of new recruits in the context of a difficult recruitment environment. Congratulations. Jamie is a great guy, but he just is proof in the pudding that it can be done. And I do think that the reputation of the Regional Health Science Center is a big part of it, including your leadership. So congratulations on that. What people don't know is that medical students and residents in their training have a certain number of defined weeks where they can do electives, where they can make up gaps in their education. But they also can explore areas where we may not necessarily have a lot of the specialty and subspecialty areas. You know, dermatology has been one of them, and the students have been dismayed. For the class of 2021 and the class of 2022, the electives have been shut down across the country. So normally they'll go to other parts of Ontario or across the country to work with people, and some of it is an audition to get their next residency position. But for residents, it's filling in some of the gaps that we don't offer here. The recruitment strategy is just completely solved and potentially offered solutions for us that the medical school has been struggling with even in the last 2 days. So having these experts brought on board really revitalizes our approach towards addressing the anxiety of our students who feel that, you know, they can't compete with the U of T students. And so this is a fantastic, really fantastic direction to be going in. The other thing I think, you know, it's not obviously, there are no guarantees for us, but medical school expansion is definitely imminent from all the signs we're hearing from the Ontario government, which means that we have been talking to Jean and Zaki and Stuart about where we can potentially expand our residency program. This is fantastic. Finally, I'm just really pleased you mentioned the Urology Fellowship because that is a first. But, you know, I opened up that field in Toronto, and it is a potentially hugely positive field for us, not just in the way that we can access, you know, training in parts of the world where, you know, we might necessarily feel it's not entirely needed, but it is. And in fact, our influence in offering training in Canadian environments has a positive impact on those other cultures. As well, from a social accountability perspective, we can actually, now that we're getting experience with fellowships, start open fellowships with many other communities who feel that they may not actually get some of the exposure to rural, remote, and cultural, especially Indigenous, training that they need to be confident in the area. So I know that really wasn't a question, Zaki, but it would be actually a really fantastic support for you in the work that you're doing. And just because Jamie's leaving, you know, everybody wants to go to BC, but really, we've got better views in Thunder Bay, so we'll recruit somebody else, I'm sure.
Thank you, Sarita. Great comments. Very true. It's an impressive lineup there, so thank you.
Okay, just one more comment, Dr. Sarita. One of the reasons why we kept borders instead of Northwestern Ontario, which we used in the first wave, to Northern Ontario was for the NOSM students so they could continue doing their rotations across the north, and all the NOSM sites would be included.
Again, thank you so much for your thoughtfulness on that. I think this is just another example of the medical school and the Regional Health Sciences Center are actually collaborating extremely well with the renewal of our affiliation agreement. I'm really excited about this.
Great, thank you. Thank you. I'm watching the clock. Do we have anybody that I've missed for a question? And we'll move on to the next section if we can. Okay. Dr. Med, thank you very much. I did flip things by mistake. I just wanted to save Michael for a little bit later, so it was all planned, Michael. Sorry about that. But I'd like to reintroduce to the group Michael Belnim. He's the Director of Strategy and Performance, and I'd like to tell Mike or invite Mike to present our first quarter scorecard. Michael?
Thank you. So there is a briefing note in your package and a scorecard. It's not really a strategic update. As you'll recall, I think we finished our 2020 strategic plan late last calendar year or into January of 2020. And we have not yet landed a new strategic plan. So what we've done is carried over the indicators to continue to keep you informed on how we're doing with respect to the indicators that we had chosen for 2020. And there's a written report here that explains some of those. So similar format with the scorecard. You can see there's quite a bit more green than there was in the past, which is encouraging. And the explanations are in the report. I won't go into too much detail on this, but I'm happy to answer any questions or hear any comments.
What impresses you the most? There is green. What impresses you the most with that when you look at that? If you had to pick one.
I think we're making some improvements on hand hygiene. These numbers are actually fairly low in terms of the survey counts that we're using. We just introduced a new infection prevention and control software system that's taken a bit longer than expected to ramp up. So we expect those results will continue to improve. I think the staff are certainly aware of the importance of hand hygiene now more than ever. I'm pleasantly surprised with the improvements that have been achieved in the in-hospital deaths following major surgery. Those numbers were always a little bit concerning. I think there's an explanation as to what was driving that previously. That number has come down in the fourth quarter of last year and in the first quarter of this year. The numbers are fairly small. In total, about 50 deaths on a baseline of 2,800. 2,800 is the numerator, or the denominator rather, for the calculation. We do about 14 to 15,000 surgeries a year, so the mortality rate is actually a very small number, 0.2 or 0.3%. But this is a risk-adjusted number, and we do kind of monitor this pretty closely. And I think the surgical leadership and the surgeons have really stepped up and looked at the data on a regular basis, and they're paying a lot of attention to it. I'm also happy to see that the 90th percentile ER length of stay improved quite a bit. Our occupancy, that particular metric is very sensitive to the occupancy that we're running, and we were averaging about 75% occupancy in the first quarter. So that low number is somewhat to be expected, but at the same time, it was also important that we were actually able to achieve that improvement because there were distancing issues in the emergency department due to COVID that meant that we really needed to move patients a lot more quickly from the emergency into beds to avoid congestion and to avoid the potential for contamination and to give the staff some room to work. So we're happy with that result as well. I think the last one I would make a specific comment on is the patient satisfaction results for all dimensions. So we continually raise the bar for ourselves on this, and the numbers continue to improve. I think it's important to note that the academic average for Ontario is about 66% and has stayed pretty flat over the last several years, whereas our results have continued to improve. We're up about 5 to 6 points over the last 4 to 5 years. So we're going up by about a percentage point or a little better than that on an annual basis. And that's a real tribute to the people that are working hard in PSCC and the leadership that are paying attention to this on a daily basis.
Thank you. Any questions or comments for Michael?
Well, this is probably a story here just because I have a learning disability when I read charts. I find the trending part of it a bit confusing. It sort of misled me. When I looked at it, I know it's supposed to address improvement when it goes down, but it almost made me feel like it wasn't a good thing. So anyway, I just thought I'd point that out for those of us who are not statistically inclined. It was a bit hard to read.
Get a little deeper there, Sarita. What's confusing?
It's just me. I'm sure it's just me, but if you look at it at a glance, and you see something that's trending downwards, you think it's actually a bad thing. And in fact, it's a good thing because of the indicators that we have in place. So I found adding that a little harder. I had to remove that column for me to better understand the data that was in front of us. And it's probably just me, Matt, so don't worry about it.
Okay, we'll go on to the next person. No, I'm joking. Okay, thank you. Joy. You're on mute.
Yeah, sorry, I changed the format of the screen. I couldn't find where the mute button was. I have a question with respect to a couple things. Number one, the pressure ulcer, is there a reason we didn't have data with respect to that? It looked like the chart only had 1 or 2 data points on that. I wasn't sure if I forgot when there was a previous explanation for it. Question number two was with respect to sick time. If we had considered doing some kind of staff survey with respect to that, because there were comments indicating that we've had difficulty tracing what the reason is in terms of trying to figure out how to address those issues. And then last, and this is a little more sort of abstract, but in terms of we last year, I believe, dropped off the top research hospitals. And I was wondering whether or not we had given any consideration to whether measuring the number of research staff might be replaced with a better indicator that we can keep track of in terms of keeping our status as a research hospital or re-obtaining that status.
Okay, for the pressure ulcers, we don't monitor pressure ulcers, or we don't audit pressure ulcers on a regular basis. We do it typically in the second quarter and in the fourth quarter of a fiscal, and there's a fairly extensive review process that's conducted by our CNS, our clinical nurse specialist leadership, that actually goes in and pulls charts and reviews the incidence and prevalence of pressure ulcers within patients. So that's why we don't have any for Q1.
Why are we doing this just a couple of times a year?
Well, it's a pretty laborious process. So, and I think they're paying attention and monitoring through the incident reporting system what the results are, what they look like, and where we have an encounter. I know that there are some measurements that CII is suggesting with respect to patient harm, which may actually help to shine a brighter spotlight on this on a more routine basis. But for now, this is the way that we're actually monitoring it. There is no
other reason is because our numbers are so good compared to industry standards. If you look at the metrics we compare to, we're 5 to 6% below the provincial average. So there's no reason to invest more than, unless we see the numbers creep up. At this time, it's more monitoring than actually measuring, if you like. Because of what Michael described, it's a very onerous process, and we need our CNS more involved in teaching than actually running numbers.
With respect to the sick time, there's a lot of engagement that has already been completed, and there's an active project that we have underway currently to dig even deeper than we've done in the past into what's driving our sick time. There are some preliminary explanations in the briefing note. Part of the challenge is that we have been working with some significant shortages in a number of our areas, which means we've got some significant overtime rates, when staff work a lot of extra hours, and we don't have a lot of people waiting to backfill and provide support for them, it's more likely that they're going to get sick. So we have heard some of that from them, and the data does support that. But we will have, we think, some additional findings to brief you on in the next quarter on what our efforts are able to demonstrate. With respect to the research indicators, this particular one was chosen 5 years ago in conjunction with TBR-HRI. They're in the process right now of revamping their indicators and refreshing them. So I'm working with Kelly and her team on coming up with some measures for TBR-HRI, and we'll see if some good ones come up through that discussion. I don't know that that total research staff is necessarily one of the indicators that's being used to assess our standing with respect to research hospitals, but I see Peter has his hand up. He may want to comment.
Let me just jump in there. I think one of the key pieces on that, I don't know if for a fact, but for top 40 research hospitals is the dollar spend. And if you look back 2 or 3 years ago, it was a cyclotron was part of here is there's a lot of hospital services that are provided in kind, but those aren't captured in the financial statements, so they are now. So there's probably, if I recall, $1.5 to $2 million worth of in-kind services, so whether that's financial services or HR or ITIS rent that's not charged, but there is a value to that, so that's now been added to the revenue. I think that would be a bigger driver of getting back into the hospital.
Okay.
Again.
Andy? You're on mute, Andy.
And Peter, has that been corrected now with the microphone?
Andy, you're.
What's going on here?
Fine.
Sometimes you hit a key by accident. If you have a keyboard connected, you can sometimes mute it by accident.
So Andy, put your hands up and you can go ahead and talk.
Good time.
Okay, I'm going to speak on. Has that been corrected, Peter, with regards to the tax report? As far as I know, with research rankings, by and large, the biggest thing is money.
Yeah, so the cycle cost, when you say hasn't been corrected, it's actually been moved to the hospital site, so those costs are captured there. As far as the corrected piece is the capturing of the in-kind costs that the hospital provides. So in the past, the last, for example, wasn't captured as a cost, now it's captured as a cost and a contribution that kind of varies by the hospital. So it's offsetting, so it does increase the expenses of the RI by about $1.5 million. Right off the top of my head, but it's that range.
Thanks, Michael. That was helpful. Oh, sorry, Pam. I didn't. Go ahead.
Okay, I was just going to say, I wonder, is this also impacted by the fact that we're down significantly in terms of the number of full-time researchers we have at the Research Institute? Is that part of what's impacting this evaluation?
It's only money. The ranking is money spent on research, and what Peter did this year will be a better reflection of what stand research has in the Thunder Bay region.
Joy?
If I could ask a follow-up question, so Mike, based on your and you and Jean's comments with respect to information collecting that may be laborious and sort of low priority right now, particularly during times where we have many other more important priorities. Has there been any thought given to what kinds of things we might need to stop auditing or looking at so that we can redirect those auditing resources to things that are more of a priority for our hospital right now?
Absolutely. That's the short answer. Definitely. And we discussed this at the IMF meeting last weekend and back at the Senior Leadership Council meeting. We have a plan to do a more formal analysis of all the projects, including capital and ongoing operations, such as budgeting, for instance. We are looking at criteria to guide our directors and leaders in identifying what can be stopped, what can be removed, delayed, and what needs absolutely is essential and must be maintained. And we're looking at a formal assessment tool. Jessica Legozo and myself, and then shared with the senior team, will come up with this tool in the coming days so that we can actually do a formal assessment. We have an inventory of all the projects that are currently on our working table, and we definitely recognize that we cannot continue at this pace given the pandemic crisis we have to manage at the same time, but we don't want to jeopardize the hospital's reputation or the hospital's mission, which will all be part of the assessment. Okay?
Okay. I don't believe I see any other questions. I would like to add just a comment because, I mean, we're in the middle of a pandemic, but for those of you on the line who maybe haven't been in the hospital for a while, I have, and I'm curious to see the correlation between some of our measurements versus the environment that we have right now, in that we've got a very, of course, we're in the middle of a pandemic, but the hospital is operating extremely efficiently. It's very clean. I would imagine that would translate to employee satisfaction, albeit we've got some challenges. I'm curious just in the months ahead to see what that yields, because and I also personally, as I've told John, it's an opportunity potentially for us to reset in terms of, from an operational standpoint, what this could actually be. And everything from, we've talked about the importance of masks to be worn to visitors. I use as an example, when a family member passed 2-3 years ago, there was 20 of my family outside that hallway for a long time. At the time, it didn't seem wrong. To me now, I think there's a different way to go about doing it. I hope these are some of the things that we'll see come out. So great work, and Michael, thank you for that very much.
Thank you.
Thank you. Okay. I will turn things over to Pat Lang. Pat is our chair of our Patient Safety Quality Care Committee. Pat, over to you. Thanks, Mike. She got mute. Pat, you. Does she have to click it? Go ahead, Pat.
Okay, thank you. Just in terms of the form, the question that Sarita brought forward, I will ask Kelly and Michael to look at that form, and we will look at it in more detail at the Patient Safety and Quality of Care Committee. The two areas that I was going to speak about, one is the pandemic response. We did have a presentation at our September meeting, and really the conversation that we've had today and the comments from our CEO and our chief of staff and the responses from the senior leadership team really indicates their dedication and their commitment to ensuring that we continue to provide quality patient care during this time. One of the things that really impressed us at the Patient Safety and Quality of Care Committee was the fact that the team continues to use their learnings to make things better for the staff and for the patients. And an example of that is that we did a survey, and they also went back and took a look at where we received patients' complaints from. And the majority of the patient complaints were related, 75% of those complaints from the patients related to policies that we had to develop related to COVID-19, communication between the care team and the family, the restrictions for the essential care partners, security issues, and care partners refusing to wear masks. And these are all things that have been addressed as we're looking at moving into phase 2 of COVID-19. So I really appreciated the fact that staff are committed to continuing to make improvements along all of these lines. And one of the things they're doing is going to be including the patient family advisors at all levels, from the incident management team through to the working group. So thank you to the staff for your leadership and your dedication during this very difficult time. The other presentation that we have is on the women and children's programs and services. And the strengths from that are, first of all, the staff members are extremely dedicated and passionate about the quality of care for women and children, and they're truly committed to patient and family-centered care. The challenges that they face are mostly related to the fact that we have small patient volumes of only about 1,000 births per year, and they lack the resources to support medically complex children in Northwestern Ontario. We do have a partnership, I believe, with Southwestern Ontario, with the London Hospital, where they work very closely to ensure that the patients do receive the care that they need when they are in these medically complex situations. And on the other hand, the staff members are extremely committed to creating a center of excellence for family and child care at our hospital. Those are the two areas, Mr. Chair, that I wanted to report on, and I'm open to any questions or comments from my colleagues.
Thanks for the report, Pat. Open it up to the floor. Okay. Thank you, Pat, for your update.
Thank you.
Thank you. I note that items 7.1 through 7.8 are included in your package for information purposes. Everything from work plans to the report on the Volunteer Association. I would ask at this point if there are any other comments from any of the board members on the line that we've missed or that you want to comment on. Hearing none, I will state in the next regular board meeting of the hospital board, if regular is a word we can use these days, will be Wednesday, November the 4th. We may be doing it in the exact same format to respect social distancing and obviously the pandemic we're going through. I want to thank everyone for attending, and this meeting is officially adjourned. We'll move into in camera. Thank you.